Your feet are sending signals. Most people over 60 have learned to dismiss a lot of what their feet are telling them. Some aching here, some stiffness there, maybe a little numbness on a cold morning. Age, they figure, nothing to worry about. But there is a specific category of foot changes that are not simply age-related wear, and dismissing them costs time that matters. Because in the context of diabetes, particularly undiagnosed or poorly managed diabetes, foot changes are among the earliest and most consistent warnings the body produces. They are earlier than most cardiovascular symptoms. They are earlier than kidney changes that show up on blood tests. And they are visible, touchable, and observable in a way that internal warning signs are not. If you know what to look for, your feet are one of the most informative diagnostic surfaces on your body. Before we go further, an important note. This channel covers general education, not medical advice, and I am not your doctor. Nothing here is a diagnosis. Several of the changes I'm going to describe warrant prompt medical evaluation. I will tell you which ones as we go through them, and I want you to take those seriously. If you are currently experiencing an open wound, a sore that will not heal, significant swelling in one foot, or sudden loss of sensation in either foot, please contact your physician today, not after finishing this video. Those presentations are time sensitive. With that established, drop your age in the comments and let me know if any of these match what you have been noticing. I read them. And stay through number 4. It is the change that most people chalk up to dry skin or poor circulation, and the mechanism behind it has nothing to do with either. Let us go through all 9, starting with the most common and counting down to the most urgent. Number 9. Dry, cracking skin on the heels and the balls of the feet. Most people have had dry feet at some point. What distinguishes diabetes-related skin changes on the feet from ordinary dryness is the pattern, the persistence, and the location. Elevated blood glucose over time disrupts the function of the sweat glands in the feet, a process mediated by autonomic neuropathy, damage to the small nerve fibers that control glandular secretion in the skin. When those nerve fibers malfunction, sweat production in the feet decreases or stops. Sweat is the skin's primary mechanism for maintaining its own surface moisture. Without it, the skin of the foot, particularly the heel and the pressure points of the ball, loses elasticity and begins to crack. The clinical term for this is anhidrosis, and it is one of the earliest autonomic signs of peripheral neuropathy in diabetes. The distinction from ordinary dry skin. Routine dryness responds reasonably well to moisturizer applied consistently. Anhidrosis-driven dryness is far more persistent, returns quickly after moisturizing, and tends to concentrate in specific pressure zones rather than being distributed evenly across the foot. The cracks that result from severe heel dryness and diabetes can also become entry points for infection, which matters enormously in a foot whose immune response and blood supply are already compromised. If you have been treating persistent heel cracking for more than a few weeks without meaningful improvement, and you have other risk factors for diabetes, excess weight, family history, hypertension, previous gestational diabetes, this is worth raising with your doctor, not as an isolated complaint, but as part of a broader picture. The clinical value of this sign is precisely that it is early. Autonomic neuropathy affecting sweat glands in the feet can appear before sensory neuropathy produces numbness or tingling. The person who notices persistent anhidrosis-driven heel cracking and investigates it often catches elevated blood glucose years before the more serious complications develop. That is the window where intervention does the most good. Number 8. Changes in hair growth on the legs and feet. This one surprises people. The fine hair that covers the lower legs and the tops of the feet is fed by capillaries, the smallest blood vessels in the body. And those capillaries are among the first structures damaged by the sustained elevated glucose levels of uncontrolled or undiagnosed diabetes. The glucose-mediated damage to the endothelial cells lining the capillary walls reduces blood flow to the hair follicles over time. When follicles receive insufficient blood flow, they produce thinner, sparser hair and eventually stop producing it at all. The progressive loss of leg and foot hair is a recognized sign of peripheral arterial disease and of the microvascular complications of diabetes. In a clinical context, a physician examining a patient for diabetes-related foot risk will specifically look at hair distribution on the lower extremities as one of the early indicators of vascular compromise. The practical observation is simple. Compare the hair distribution on your lower legs now to what it was 5 or 10 years ago. Patchy, thinning, or absent hair on the lower legs and the tops of the feet, particularly when combined with other signs on this list, is a signal that peripheral circulation may be impaired and that a vascular assessment is warranted. A simple clinical test called the ankle brachial index, which compares blood pressure measured at the ankle to blood pressure measured at the arm, can identify significant peripheral arterial disease in about 10 minutes at a physician's office. A normal ABI is between 0.9 and 1.3. An ABI below 0.9 indicates peripheral arterial obstruction. It is a painless test, requires no preparation, and can be performed at most primary care or cardiology offices. If you have noticed progressive loss of lower leg hair and have not had an ABI measured, it is worth asking whether one is appropriate at your next visit. Number 7, a persistent feeling of coldness in the feet even when the rest of the body is warm. This is distinct from the kind of cold feet most people experience in a cold room or during a cold night. The relevant presentation here is feet that feel significantly colder than the rest of the body in a warm environment, or that take an unusually long time to warm up after cold exposure, or that feel cold even when they are objectively warm to the touch, which is the neuropathic variant. The first mechanism is vascular. Peripheral arterial disease, accelerated by the vascular damage of chronic hyperglycemia, reduces arterial blood flow to the feet. Blood carries heat. Less blood flow means less heat delivered to the tissue. Cold, poorly perfused feet in a warm environment are a peripheral circulation problem until proven otherwise. The second mechanism is neuropathic. Damage to the sensory nerve fibers that detect temperature, a component of small fiber neuropathy, can produce distorted temperature perception, where the feet feel cold even when they are not, because the thermal sensing mechanism itself has been disrupted. Both mechanisms can be present simultaneously in diabetes, and distinguishing between them requires clinical evaluation. The take-home observation. If your feet feel persistently cold compared to the rest of your body in conditions where they should not be, this is worth documenting. When it happens, how long it lasts, whether both feet are affected or one more than the other, and bringing to a physician. Bilateral persistent coldness suggests vascular disease affecting both lower limbs. Peripheral arterial disease is the primary consideration, and its association with diabetes is well established. The combination of high blood glucose and the abnormal lipid profiles that often accompany insulin resistance accelerates atherosclerosis, the buildup of plaque in arterial walls, in the peripheral arteries of the legs and feet at a rate considerably faster than in non-diabetic individuals. Unilateral coldness adds the possibility of a more focal vascular obstruction and warrants more urgent evaluation. Number 6, swelling in the feet and ankles, but specifically asymmetric swelling. Bilateral ankle swelling, both ankles swelling equally, is common in older adults and has many causes, including venous insufficiency, heart failure, and medications. It is worth evaluating in its own right, but it is not specifically a diabetes signal. Asymmetric swelling, one foot or ankle significantly more swollen than the other, is a different matter and deserves prompt attention. In the context of diabetes, unilateral foot swelling can be a sign of one of two serious conditions. The first is a deep vein thrombosis, a blood clot in the deep venous system of the leg, which produces unilateral swelling, often with warmth and tenderness along the inner calf. DVT is a medical urgency. The second, and the one more specifically associated with diabetes, is Charcot arthropathy, also called Charcot foot, a condition in which neuropathy so completely abolishes the pain sensation in the foot that minor injuries go unnoticed, joints and bones sustain repeated undetected trauma, and the foot's architecture gradually collapses. Charcot foot typically begins with warmth, redness, and swelling, often in the midfoot, that is painless or nearly so, precisely because the neuropathy that caused it has also eliminated the warning signal. Many patients with early Charcot foot are initially misdiagnosed as having an infection or a sprain. In the context of known or suspected diabetes, a warm, swollen, painless, or minimally painful foot should be evaluated as a possible Charcot presentation until proven otherwise. It is a complication that is far easier to manage when caught early. If you have one foot that is significantly more swollen, warmer, or redder than the other, contact your physician promptly. This is one of the presentations I mentioned at the beginning that is time sensitive. Type the number 6 in the comments if this one surprised you. Number 5. Slow healing cuts, blisters, or skin breaks on the feet. This is one of the most clinically significant items on this list, and it deserves a careful explanation of the mechanism because understanding it changes how seriously the symptom is taken. In a person without diabetes, a small cut on the foot follows a predictable healing sequence: immediate clotting, local inflammatory response to clear debris and bacteria, proliferation of new cells at the wound margin, and final remodeling of the new tissue. In a person with chronically elevated blood glucose, every step of this process is impaired. Elevated glucose reduces the motility of the white blood cells responsible for clearing bacteria from the wound, slowing the immune response. It impairs the function of fibroblasts, the cells that produce the collagen scaffold on which new tissue is built. It reduces the angiogenesis, the new blood vessel growth, that delivers oxygen and nutrients to the healing tissue. And the peripheral neuropathy that often accompanies chronic hyperglycemia means that minor injuries go unnoticed long enough for bacterial colonization to become established before the person even realizes a wound exists. The practical consequence is what the clinical literature calls a diabetic foot ulcer, a wound that does not follow the normal healing timeline and can persist for weeks or months, eventually becoming colonized with bacteria and potentially progressing to infection in the underlying tissue or bone. Diabetic foot ulcers are the leading cause of non-traumatic lower limb amputation in the United States. They are preventable when caught early and managed aggressively. A wound on the foot that has not shown clear signs of healing within 2 weeks, particularly in someone with known or possible diabetes, is a medical matter, not a wait-and-see matter. Please do not wait. And the 2-week marker is a maximum, not a comfortable deadline. A wound that looks worse after 5 to 7 days, more red, more swollen, beginning to show any discoloration of the surrounding skin, or producing discharge that has changed from clear to cloudy or dark, is a wound that should be seen before 2 weeks. The 2-week guideline applies to a wound that is simply not progressing as expected. Active worsening is a shorter timeline. If you see red streaks extending from the wound, feel warmth or tenderness spreading beyond the immediate wound margins, develop fever, or notice a foul odor, those are signs of advancing infection and warrant same-day care. Number 4. This is the one I told you to stay for. Skin color changes on the foot, specifically a dark, velvety discoloration in the creases and folds of the skin, particularly around the ankles, the back of the heel, or between the toes. This change is called acanthosis nigricans when it appears in skin folds such as the neck and armpit, which is where most discussions of it focus. But the same or similar pigmentary changes can appear on the feet and ankles in a form called diabetic dermopathy when they are on the shins, and as a more generalized hyperpigmentation in the folds of the foot. What drives the color change is not poor circulation and not infection. It is insulin resistance, specifically the effect of chronically elevated insulin levels on the skin cells called keratinocytes and melanocytes. When insulin resistance is present and the pancreas compensates by producing more insulin, the excess insulin binds to receptors on skin cells that are normally activated by insulin-like growth factor. Stimulation of those receptors causes the skin cells to proliferate and produce more pigment. The result is a darkening, thickening, and velvety texture in skin folds and creases that has nothing to do with sun exposure or skincare. It is an insulin signal written on the skin. The reason this is one of the most important signs on this list is that acanthosis nigricans and related pigmentary changes can precede the diagnosis of type 2 diabetes by years. They appear during the insulin resistance phase before blood glucose rises enough to produce symptoms or to trigger a diabetes diagnosis on a standard blood test. A person who notices this change on their feet, neck, or armpits and has not recently had a fasting glucose or HbA1c test is carrying a signal that warrants a straightforward blood test. That is all. A blood test that is either reassuring or actionable that is worth making an appointment for. Number 3, tingling, burning, or a pins and needles sensation in the feet, particularly at night. This presentation is so common in diabetes that it has its own clinical name, painful diabetic peripheral neuropathy, and yet the majority of people experiencing it are not connecting it to their blood sugar. Peripheral neuropathy in diabetes begins in the small nerve fibers, the unmyelinated C fibers and thinly myelinated A delta fibers responsible for detecting pain, temperature, and light touch before it affects the larger fibers responsible for vibration sense and proprioception. Small fiber neuropathy produces symptoms before large fiber neuropathy produces findings on a standard neurological exam, which means a person can have significant symptomatic small fiber damage, burning, tingling, hypersensitivity, or the sensation of wearing invisible socks, while their formal neurological testing still looks relatively normal. The nighttime predominance of neuropathic pain has a physiological basis. During the day, sensory input from activity, footwear, and the constant stimulation of walking provides competing neural noise that partially masks the neuropathic signal. At rest, that competing input disappears and the neuropathic signal becomes a dominant sensory experience. The burning that wakes people up at 3 in the morning, the inability to bear the weight of a bedsheet on the feet, the feeling that the floor is slightly wrong even when walking, these are neuropathic symptoms, not circulation symptoms, and they are among the clearest indicators that the peripheral sensory nervous system is being damaged. Neuropathy from diabetes is not fully reversible once established, but its progression can be slowed significantly with tighter glucose control, which makes early identification critical rather than incidental. A study published in the New England Journal of Medicine following patients in the diabetes control and complications trial found that intensive glucose management reduced the incidence of clinical neuropathy by 60% compared to conventional management over a 6.5-year follow-up period. That number is worth sitting with. 60%, not a modest reduction, a majority reduction achieved by managing the variable that is most directly within clinical reach. The burning you feel at night is not a fixed outcome. It is a signal about where the glucose management stands and a prompt to tighten it with your physician's guidance before more fibers are affected. Number 2, numbness, the absence of sensation rather than the presence of abnormal sensation. If tingling and burning are the early neuropathic warning, numbness is what follows when the nerve damage has progressed further. The loss of protective sensation in the feet is the condition that makes all the other complications on this list dangerous in a way they would not otherwise be. It is the reason a small cut goes unnoticed until it is infected. It is the reason a Charcot fracture occurs without pain. It is the reason a blister from new shoes turns into an ulcer. Numbness in the feet from diabetic neuropathy follows a characteristic stocking glove distribution, beginning in the toes and the ball of the foot, spreading proximally toward the ankle and the lower leg over time. The clinical test most commonly used to assess protective sensation is the monofilament test, a standardized nylon filament that applies a known force to specific points on the sole of the foot. Inability to feel the filament at one or more sites indicates loss of protective sensation. This test takes less than 2 minutes and can be performed at any primary care appointment. If you have not had one and you have diabetes or significant risk factors for it, ask for it specifically by name. At home, a simple self-assessment. Run a finger lightly along the sole of your foot and compare the sensation to your palm. A meaningful difference in sensitivity between the two, particularly reduced sensitivity on the sole, is worth reporting. Never attempt to test foot sensation with anything sharp or potentially injurious. The point of the test is to detect the loss of protection that would make such a test harmful. The 10-gram Semmes-Weinstein monofilament, the standardized device used for this test, is available for purchase online and can be used at home for self-monitoring once a person has been shown the correct technique by their care team. Organizations including the American Diabetes Association recommend that adults with diabetes perform monthly self-foot inspections and have annual clinical foot exams, including monofilament testing. Monthly inspections mean looking at the bottom of both feet, using a mirror on the floor if necessary, for any skin breakdown, color change, or swelling. This is one of the most powerful and most underused self-care practices in diabetes management, and it costs nothing beyond 2 minutes and the willingness to look. Number 1. An open sore or wound on the foot that is not healing, or that you did not notice until it was already significantly developed. I place this at number 1 not because it is the most common finding, but because it is the most urgent and the one that carries the most directly time-sensitive consequences. A diabetic foot ulcer that has been present for even a few days without treatment can progress rapidly. The combination of impaired immune response, compromised blood supply, and absent protective sensation means that bacterial colonization can advance to deep tissue infection, cellulitis extending into the fascia, the tendons, or the bone, in a time frame that would not apply to a wound in a non-diabetic foot. Osteomyelitis, bone infection from a foot ulcer, is one of the primary reasons for lower limb amputation in diabetes, and it can develop from a wound that looked minor just days earlier. If you are looking at your foot right now, and there is any open area, any wound, any sore, any area of skin breakdown, and you have diabetes or have reason to suspect you might, this is the moment to call your physician, not the end of the video. That call is more important than anything else here. I want to say something directly about how many people with diabetic foot ulcers delay that call. Studies show that the average time between a patient first noticing a diabetic foot wound and seeking care is more than 2 weeks. 2 weeks in which the wound deepened, bacteria established themselves, and the treatment options narrowed. If this video changes one thing, I want it to be that number. Here is the picture when all 9 are held together. Your feet, in the context of diabetes risk or existing diabetes, are not passive anatomy. They are the most peripheral, most vulnerable, and most informative territory in your body because the blood vessels are smallest there, the nerves are most distal there, and the skin is under the most constant mechanical stress. The changes diabetes makes to circulation and nerve function appear there first and appear there most consequentially. A foot examination, done by a physician, a podiatrist, or a trained diabetes care nurse, should be part of every older adult's annual care if they have diabetes, and should happen at least once for anyone who has not been tested for diabetes recently and has the risk factors: age over 45, family history, excess abdominal weight, hypertension, previous gestational diabetes, or a prior blood test showing prediabetes. The examination takes minutes. The blood test that checks for diabetes, fasting glucose, and HbA1c takes a single tube of blood. Neither of these is complicated. Neither of them should require a dedicated appointment in many practices. Ask for them. If someone in your life over 60 has never been screened for diabetes, share this with them. The information is free. The consequences of not having it are not. And I want to end with something that is worth saying plainly. Foot complications from diabetes are among the most preventable serious medical outcomes in chronic disease management. They are not inevitable. They are the result of a specific chain of events: elevated glucose, vascular damage, neuropathy, impaired healing, undetected injury, where each link can be interrupted if the signal is recognized early enough. You just learned 9 of those signals. That is not a small thing. Tell me in the comments, which of these 9 have you noticed, and how long ago did you first notice it? That information matters, and it may help someone else reading the comments who is trying to decide whether their own symptom is worth a call. Next, I want to walk you through the specific HbA1c number that most people with prediabetes are not told to watch closely, and why the difference between 5.7 and 5.9 is more significant than most people are ever told. Watch that one next.